Hey everyone, so this semester is going to be a little bit different from now on, and we're going to be doing online lectures. So listen for some good information, and somewhere in here will be a discussion board question that we'll use to make sure that you will listen to the entire PowerPoint, and then we will talk about questions later. So today we are going to be talking about medications that affect coagulation, Chapter 9 in your book. So some different things we're going to cover today. We're going to look at some different terms and abbreviations. We're going to talk about the physiology of a blood clot, and we're going to define some other terms as well. We will also discuss some various types of hemostatic agents, how they're used, different side effects, any contraindications, and how they are administered. Sorry for the little human at the end of that last slide. So coagulants and anticoagulants are going to serve two different purposes. Anticoagulants these are the agents that inhibit blood clotting, so they're going to keep you from getting blood clots. On the opposite end of that are coagulants. These are agents that promote, accelerate, or make possible blood coagulation. What hemostatic agents do is they enhance or accelerate blood clotting at a surgical site. And then keep in mind thrombolytics, these dissolve existing blood clots. Now we're going to talk a little bit about the physiology of clot formation. So naturally, blood will have coagulants and anticoagulants. Ideally, blood's going to move smoothly through vessels. In the case, though, of a damaged vessel, this doesn't actually happen. Also, anticoagulants are going to be dominant. They are what keep the blood in a liquid form. So whenever that blood vessel does get damaged, that's when the coagulation mechanism starts forming clots to prevent someone from losing a lot of excess blood. Natural coagulation is effective when the damage is minor, like if you get a paper cut to your finger. It's going to be effective on venules, arterioles, and capillaries. So you'll notice these are all small structures. The body's natural anticoagulants serve some very specific and very important functions. Natural anticoagulants, they're going to prevent undesired clotting in undamaged vessels, so we're talking about blood clots here, and they also interfere with the clotting sequence. The body's coagulation mechanism prevents blood loss resulting from trauma or damage to small blood vessels. This process is actually a cascade of events that occurs in three basic stages. The first, thromboplastin forms, then it converts prothrombin into thrombin, and thrombin converts fibrinogen into fibrin. So if you take a picture, or take a look at the picture here, you'll notice the first picture is just the damage basically to the capillary wall here. So the blood vessel's injured first. And then stage 1 and stage 2 are kind of combined into the second picture. This is the clumping of the platelets. Oh, there goes my highlight. And then the third stage, when fibrin actually is formed, this is the clot formation that they show in this third picture here. The blood clotting cascade can happen in a couple different ways. This picture is also in your book if you want to look at it closer. There's either the intrinsic pathway or the extrinsic pathway, which we'll talk about both of these in a little bit more detail coming up. Stage 1 of clot formation can happen by two mechanisms. Extrinsic, which is initiated by factors outside of the blood, or intrinsic, which is initiated by factors contained in blood. Both of these are going to form thromboplastin. The extrinsic pathway can produce a clot in seconds. It's going to start with factors outside the blood that are released from the tissue that's been damaged, and then after that, a bunch of different blood coagulation factors are going to play roles. This slide goes into a lot more detail than I'm going to talk about. I just basically want you to know that there is a pathway, but you aren't going to have to know any of the certain factors or anything like that. The intrinsic pathway is another option in stage 1. So this is going to be initiated by substances inside the blood. It's going to be a lot more complex, and it'll take several minutes to complete as opposed to seconds in the other pathway in order to produce a clot. Similar, though, to the extrinsic pathway, it will involve some blood coagulation factors that are shown here. and some are going to be the same as the extrinsic pathway. Again, you don't have to know details on these. I just want you to kind of see what they are. So as a summary of this first stage of blood clotting, it's essentially just the formation of thromboplastin, and there are two pathways to achieve it, extrinsic and intrinsic. In stage 2, this is where we're going to take that thromboplastin that we formed in stage 1, and we're going to use it to convert prothrombin to thrombin. The third stage of blood clotting, this is when thrombin converts fibrinogen to fibrin, and this will create a clot net. If you look at the picture, figure 9.2, it's an image of fibrin net trapping red blood cells on there. So obviously I broke this down pretty simply, but it's not going to be as simple as this. It's going to have the right substances and the right amount at the right times. So if you remove any of these things or one is lacking, the whole cascade is going to fall apart. If you want to look up, there is a video on YouTube. It's the Coagulation Cascade Animation, Physiology of Hemostasis. You can look this up and it'll break it down a little bit more if you want to view that video. It's also important to remember that two substances are going to be really vital in this coagulation: calcium and vitamin K. Sometimes clotting can occur in blood vessels that haven't been damaged or broken, so this is going to be known as a thrombosis. Fortunately, there are medical and surgical options out there to treat this condition. You can see a picture on this slide where normal blood flow, that's going to be the vessel here on the left. And then if you see the next one, it's a DVT or deep vein thrombosis. You can see where the blood cells have actually kind of clotted up here and formed an area. And then if that thrombosis actually starts to move, it becomes an embolus. And this can be really dangerous because it can travel to the lungs, which you might have heard of a PE or pulmonary embolism. If somebody does get a thrombosis in their artery, that will require surgery. Usually pretty emergently, they're going to have to take them quickly just so you don't sacrifice any blood flow to the limb. If you think about that, if this thrombosis is blocking a vessel, you're not going to get the blood flow going to maybe to the foot if it's in the leg. And then if you're not getting that blood flow, that extremity can actually die off and become necrotic. Typically, venous thrombosis can be treated medically, so that just means blood thinners to help that clear up. Now we're going to start talking about some things that are going to be more relevant to you guys in surgery. The first type of medications we're going to talk about are coagulants. These are drugs that promote, accelerate, or make possible blood coagulation. They typically fall into two major categories: hemostatics and systemic coagulants. Hemostatics are going to be topical agents almost used exclusively in the surgical setting, so you guys will become really familiar with these. When you guys did your first set of drug cards, you were kind of introduced to some of these. And then systemic coagulants are generally going to be used in the medical setting, so not necessarily in surgery. As I mentioned, hemostatics are agents that are going to enhance or accelerate blood clotting at the surgical site. So these are adjuncts, or they're going to help along the natural coagulation in a body. They are used in surgery and applied topically, and they can be in the form of films, powders, sponges, or solutions. And you'll see a lot of these names here may look familiar from those drug cards. The first type we're going to talk about is absorbable gelatin. This is animal in origin, and it's going to be applied topically with pressure to bleeding sites. You can see all the different types listed here. Gel film, gel foam, those are going to be ones that you're specifically going to see a lot of in surgery. The packages will have some detailed usage information if you're ever in question. Obviously in surgery, if you're scrubbed in, you're probably not going to have that handy. The good thing is when you're learning, you're going to have a preceptor there telling you exactly how to handle them. But if you look up at this first one over on this top right, this is going to be, if you show, try on a little arrow there, this is going to be gel foam. So it's kind of a stiff sheet, And typically you're going to soak it either in thrombin, which we'll talk about later, or just normal saline, and then it becomes more pliable, and you can cut it into different sizes before you do that. Sometimes doctors like you to leave them in big sheets, and they can just take some forceps or tweezer-looking things to apply this to a bleeding area in the body. Also, this bottom picture, this is going to be something that you're kind of mixing at the surgical field. It'll have a liquid that you draw up in one syringe, and then it'll have the powder kind of stuff in the other, and you'll squirt the syringes back and forth, and then it'll be ready to go. It's kind of more of a flowable type of material, so you can squirt it into areas it's going to kind of form into those irregular shaped parts. Absorbable gelatin is going to, like I said, be applied topically with pressure to bleeding sites. This picture here, you can see where they've used forceps to press it on an area that's bleeding. It's used a lot in general surgery, otologic, orthopedic, neurosurgery, and like I mentioned, topical only. Overall, the absorbable gelatin is going to be free of side effects, but the one thing you don't want to do is use it when infection is present. If that infection's already present, it's just another foreign body that kind of breeds bacteria, so you definitely don't want to put. Absorbable collagen sponge. This is made from purified bovine collagen. You can cut it to the desired shape that you want and apply it with pressure again to a bleeding site. One thing with this, it comes in helostat or helatine, but you really need to be careful with this. It can reduce the bonding strength of methyl methacrylate. Methyl methacrylate, if you aren't familiar with that, what this is, it's an element of bone cement. So a lot of times when we do a total knee replacement, it's going to be something that's used on the implant to adhere that metal type substance to the bone. Also, you may be familiar with methyl methacrylate if you've ever been to a nail salon. They use this when they're putting fake nails on. That's really strong smell. It's the same thing. So this type of collagen sponge, you do not want to use it on the bone before you might put cement in, with a prosthesis or total knee implant. So just make sure to keep that in mind. Microfibrillar collagen hemostat. Avitine is going to be the one that you guys will see the most. It can come in a bunch of different forms, sheets, powders. You can see the long one there with the tube-looking thing. This one, you can actually use it in laparoscopic cases and inject it through that long tube. Okay, and here is one part of this with the microfibrillar collagen hemostat. I want you to write about this in your discussion board this week. The first thing I'm going to have you answer in your discussion board is, how do we want to handle Avitine? With dry instruments only. This is key. You learned about this in your drug cards as well. But if you use any instruments that are wet with this, it'll just stick right to the Avitine. It's not going to come off and sit in the body where you need it. So, discussion board question. This is going to be the first thing on there you need to put in. We only want to use Avitine with dry instruments. So how this actually works too is it attracts platelets, and then it's going to trigger them to aggregate into a thrombus, so it's going to get a clot formation. So also with this, uses are going to be in general surgery, otologic, orthopedic, neurosurgery. It's going to be topical administration only. And again, make sure you're only using it with dry instruments. There aren't going to be any side effects, but it is also contraindicated in the presence of infection just because it acts like a breeding ground for all of that bacteria. Another type of hemostatic agent is going to be oxidized cellulose. Typically, this is Surgicel is what we always refer to it in surgery. It's what we have at our facility. Also, Oxycel. It's going to serve as a nucleus for clotting. It will swell up a little bit when it's applied to a bleeding surface and kind of serves as a nucleus for clotting, like I mentioned. With this, you'll see the picture here. It comes in some different sizes, but it's going to be a little envelope that you peel back, and then the sterile product is going to be inside. This will be applied topically, especially in neurosurgery. It is absorbable, but once hemostasis is achieved and things have dried up, you're not having that active bleeding, it should be removed. You can see the picture a little bit better here of what that product actually looks like inside. You can see it's very pliable. It can bend back over on itself, and it almost looks like a tiny mesh. This doesn't have any side effects, but again, don't use it with infection. Thrombin is going to be a hemostatic agent of bovine origin. It's going to work by converting fibrinogen to fibrin. This, you'll notice, looks a little bit different than some of the other hemostatic agents we've talked about. It's a liquid, so it's not going to be a film, powder, anything like that. It'll come with 2 different vials. One will be sodium chloride, and then another one will be a powder formation that we have to mix up to make into a liquid. Sometimes your circulator will do this for you away from the sterile field and then put it in a Medicup for you. Sometimes you'll have the full sterile packaging on the field that you can mix it up yourself. Thrombin is going to be used a lot in general surgery. I've also seen it used in neurosurgery, but it should only be used topically, and it needs to be used immediately after it is reconstituted. It can be refrigerated afterwards, but you guys wouldn't have anywhere to sterilely refrigerate that, so that would be an issue. And keep in mind, you don't want to inject this into large blood vessels because it can cause significant vascular clotting and then therefore death. There are no known side effects with this, but it is important to note that hypersensitivity is a contraindication. So if somebody previously had a reaction to it, don't use it on them again. This table is going to be in your book as well, but it just basically breaks down all hemostatic agents that are kind of familiar to surgery that contain topical thrombin. So you can see the different brand names for that. So there are some miscellaneous agents that don't really fall into these other categories that we'll talk about. The first one is going to be bone wax. So this is made from beeswax, and it's a mechanical barrier only. So it basically just forms a physical plug to stop bleeding. It's going to be used on bone surfaces. And the nice thing about this is it's pliable and waxy, so you can basically pick off a chunk of it, which I'll show you a picture of the peel pack it comes in, and shape it into different sizes. And it can just be pressed on the bone and form really tightly on there to kind of plug it up. This is what the bone wax is going to look like, the foil wrapper that it comes in. So this will all get delivered onto the sterile field. And then you kind of peel back and you'll see that waxy substance inside. There is an instrument here. It's a freer elevator. Sometimes they like to put a little ball on the end of that and apply it to the bleeding bone surface. It's used a lot in orthopedics. Obviously, you get bleeding bone, and neurosurgery. You think about on spines, skulls, those bone edges that you're cutting into. It's applied topically, no known side effects, and it is contraindicated again with hypersensitivity. Some of the other miscellaneous agents I want to talk about are chemical hemostatics. So these are going to include tannic acid and silver nitrate, these are actually going to cauterize bleeding surfaces chemically. These kind of come in a stick form. So if you think about a really long matchstick, that's kind of what silver nitrate sticks look like. You can see here the picture. And a lot of times they're just going to grab one single one of these out to use on the patient. The tannic acid can be used for tonsillectomies to kind of chemically halt some bleeding, and then silver nitrate for wart removal. I've also seen silver nitrate sticks used in DNCs, so when they're actually doing a dilation and curettage in a female, sometimes used as a very pointed instrument to grasp the cervix, and that can leave a little bleeding spots. So I've known some physicians in the past that'll actually take one of these sticks and chemically use that to burn that area to stop the bleeding there. With these, they are not going to have any side effects. They are contraindicated for use near or on the eyes. Another chemical hemostatic is going to be Moncel solution. So this is, you can see it's almost like a thick brown syrupy looking solution. It also acts by cauterization or burning. This contains ferrous sulfate, sulfuric acid and nitric acid diluted with water. And they'll use that kind of a large Q-tip basically to paint that on to a bleeding area. Typically for a cervical cone biopsy, so we talked about Lugol solution and Moncell's solution, and not getting those mixed up. You'll remember that the Lugol solution is more of a diagnostic agent, and then this is a chemical hemostatic. So after they take that biopsy from the cervix, they can paint this on with that long Q-tip to halt bleeding. So topical administration, no side effects, and there are not going to be any contraindications. Again, make sure you're not confusing this with Lugol solution. They are both going to be brown, and you might have them both on your sterile back table at the same time. So that's why labeling, again, is going to be really important. And as I mentioned, that Lugol solution stains the cervix, and then the Moncell solution is applied after the biopsy is done, taking that tissue away, and it can halt bleeding there. So next up, we're going to talk more about systemic coagulants and anticoagulants. I talked about these are more medical as opposed to surgical, but we're still just going to kind of cover them very quickly. So these will help replace deficiencies in the natural clotting mechanism. The three types that we're going to discuss in this chapter are calcium salts, vitamin K, and blood coagulation factors. Calcium salts. So these are going to be the body's most common mineral, calcium that is. They are going to promote clotting in all three stages of the cascade. As the body's most common mineral, it's also going to be crucial to many bodily functions. You know, think about strong bones, but in this instance, blood coagulation. Calcium is going to be administered before or during surgery by an IV to restore levels and help achieve coagulation. In the medical setting, calcium may be given orally or intramuscularly. Anesthesia is going to be the ones that are monitoring blood calcium carefully. Anytime you give donated blood, the process that it goes through is going to kind of strip the blood of calcium. So they're going to really monitor the calcium levels if you're receiving donated blood as well. No known side effects, but a contraindication is patients that are susceptible to malignant hyperthermia. That condition does cause increased calcium release from muscle cells, so you do not want to combine that with calcium infusion. Vitamin K is a fat-soluble vitamin that's going to promote blood clotting by increasing prothrombin synthesis in the liver. Decreased vitamin K levels are seen a lot of times in patients on oral anticoagulants. Vitamin K deficiency can lead to excessive bleeding, so that's how it relates to us in the surgical setting. So it's really important to get these patients taken care of well ahead of surgery to replace that deficiency. If needed, vitamin K can be given between 6 and 24 hours before surgery. It takes a while to achieve an acceptable effect with this, so that's why it's not going to be done close to surgery. Ideally, it will not be given by IV. Only when other routes are not feasible will it be given by IV. And this is just because it can and has caused severe anaphylactic reactions in patients when given by IV, so that wants to be avoided at all costs. So the third and final systemic coagulant are the blood coagulation factors. They're vital to the cascade, and basically any deficiency of these can interfere with the clotting. So a couple that are shown here can be given in the medical setting, factor 8 and 9, and these are just vital links in the cascade, so that's why they would be replenished. Blood coagulation factors are used to replace a deficiency preoperatively, going to be given by IV. Factor 8 is administered to patients with hemophilia A, and factor 9 complex can be given to patients preoperatively with hemophilia B. So there is a second main group of medications that affect coagulation. These are called anticoagulants. These prevent or interfere with coagulation. They also can prevent thrombosis, pulmonary embolism, acute MI, and strokes. They do not dissolve existing clots, though. just keep that in mind. They are used in surgery to help prevent clot formation as a response to trauma or manipulating blood vessels. So if you think about vascular surgery, basically in general, they're going to be given anticoagulants, so we're not causing clots when we manipulate and cut into those vessels and mess with them um, and fix whatever the patient has going on. Parenteral anticoagulants are drugs that are administered intravenously, subcutaneously, or topically, and they interfere with blood clotting. The first one we will talk about is heparin. So it's also sometimes referred to as heparin sodium. Typically, you're just going to hear it called heparin. It's the most commonly used parenteral anticoagulant. It's going to work at several points in the clotting cascade by inhibiting factor 10 and activating thrombin, which prevents the conversion of fibrinogen to fibrin. You don't have to worry about any of those small details. Just be familiar with heparin in general. Heparin is going to be used on all vascular and cardiac surgery. It can be given by IV, sub-Q, or topical at the surgical site. A lot of times during vascular surgery, we're going to have this sterile on our back table. We're going to have it drawn up in a syringe with a special kind of what's called an olive tip. It's like a metal, not sharp needle, but used to inject this into an artery when we're working on it. So this, at a certain point in the procedure, the surgeon will ask for it, and also it is a clear substance like a lot of the other things we've talked about. Adverse reactions include an increased risk of hemorrhage and thrombocytopenia or a decrease in platelets. So it's contraindicated in patients that already have existing low platelet count. We've talked about this already, but just note that we really want to make sure to label heparin strengths too. So when we talked about epinephrine, you know that came in different strengths. Same thing with heparin. So make sure when you're getting that from your nurse, you get that information and clearly label that because it does come in different strengths and they're used in different ways in patients. You can see a bunch of different strengths of heparin here. So you can see that 1 milliliter of heparin can contain 10 units, 100 units, 1,000 units, 5,000 units, or 10,000 units. So that's a big difference between one dose to the next. So you can give somebody the same volume of heparin, but give them a dose that's 1,000 times more than what they're ordered. So, you know, you think about 1 ml, how much that is, not very much. But across the board, that can contain a bunch of different units of heparin. So that's why it's important to label and verify that number with your nurse when they're giving it to you, as well as, you know, when you're telling the doctor what you have, make sure to tell them the volume of heparin in there as well. And again, just make sure you are repeating that to the surgeon. You know, example would be 5,000 units of heparin and 1,000 mLs of saline. You'd let them know exactly what you have. Low molecular weight heparins. So these can be used outside the hospital setting because patients and their caregivers can be taught to give this drug subcutaneously. So you can see some different ones here. Lovenox is probably one that maybe more of you are familiar with. And they just inhibit factor 10 and thrombin and inhibit platelet aggregation or that clotting. Enoxaparin or Lovenox, so this is used to prevent postoperative DVT or deep vein thrombosis. And let me go to the next slide. Especially after abdominal surgery or hip or knee replacement. It's going to be a medical, not surgical use. Like I mentioned, it will be given subcutaneously. Side effects are going to be local irritation, pain at injection site, fever, and nausea. And contraindications are going to be if you have any active major bleeding or a hypersensitivity to the drug. The factor 10A inhibitor, this is going to be used post-op again to prevent DVTs and pulmonary embolisms or PEs in orthopedic, joint, and abdominal surgery patients. Make sure you're not confusing Arista and Arixtra. Arista is a topical hemostatic agent and Arixtra is an anticoagulant. So they are opposites of each other. So keep that in mind. The second category of anticoagulants are oral anticoagulants. These are going to be used for long-term management of thromboembolic disease, including DVTs and PEs. Warfarin is one agent. It's also a Coumadin derivative. It's widely prescribed. So this inhibits vitamin K activity in the liver, so it's going to help prevent formation of coagulation factors. I'm not going to tell you which ones because you don't have to know the details. This is successful in the long-term management of a number of conditions. It does take a little bit longer for onset, usually about 12 to 72 hours, but it lasts for 5 to 7 days. So you think about these patients that are coming to surgery, if they're on warfarin, it's going to take longer to leave their system. So if they've had it recently, in the past couple days, they're going to bleed a lot more during surgery. So sometimes physicians will put surgery off if they can on these patients, if it's not an emergency surgery, just to take them off the warfarin and let their blood start clotting normally, so then you're not getting excess bleeding in surgery and that increased risk of complications afterwards. There are drug interactions that are pretty common, so you have to monitor all medications closely that are being given with this. Don't want to use aspirin at the same time because you know that is another blood thinner. And there are going to be common side effects that include epistaxis, which is nosebleeds, hematuria, blood in the urine is what that means, and bleeding gums as well. So basically just extra bleeding kind of everywhere can happen. Another anticoagulant that is given orally is aspirin. You guys are probably a little more familiar with this. This prevents clot formation by inhibiting platelet aggregation. It may be given after an MI or recurrent TIAs, basically like strokes. This will prevent additional clot formation and reduce their risk basically later on. Just 300 milligrams of aspirin can double normal bleeding time for up to 7 days. So you want to be aware of that if you have a patient coming to surgery that's on aspirin. Definitely don't want to use this, as we mentioned already, with concurrent warfarin therapy. The third and final type of anticoagulant are thrombolytics. So these actually help to dissolve existing blood clots. You can see this table in your book, but it's going to give you the generic and brand names for various thrombolytics. You may be familiar with them, but they're not as common as hemostatic agents and anticoagulants. Alteplase or Activase, this is going to be an agent produced by recombinant DNA. It's the biosynthetic form of a naturally occurring enzyme, human TPA. Alteplase is used in combination with heparin to treat acute MIs. It can also help treat strokes, PEs, and peripheral vascular occlusions. It has fewer side effects because it is of human origin of an enzyme. Um, so less allergic and hypersensitivity reactions will occur. And another advantage is it's going to act specifically. It's going to target clots, rather than exerting systemic effects on the whole body itself. Okay, finishing up here with our advanced practices. So anticoagulation therapy, these are just various medication used for anticoagulation depending on the conditions being treated and the length of time the treatment is required. So a higher risk of anticoagulation is obviously going to carry a higher risk of bleeding. So we need to keep that in mind. You can refer to Table 9A in your book to see anticoagulant and antiplatelet medications. Short-term therapy of anticoagulants, this can be used intraoperatively on vascular procedures like we talked about, and also used after surgery to prevent DVTs and PEs in the surgical patient. Most common medication used is going to be heparin. With patients that are on heparin, they may do some different tests to monitor the patient and make sure they're in the correct therapeutic dosage range. They can do a PTT or a small a PTT test. And remember, heparin can cause thrombocytopenia, which is that decreased platelets. Long-term therapy of anticoagulants. This is usually necessary for patients that have vascular disease or vascular implants. When we're talking vascular implants, we're talking about maybe somebody that's had an aortic aneurysm and we have to put a graft in to correct that. Also, somebody that just has any type of graft in place that's had surgery on a vessel. That's what we're talking about, vascular implants. This long-term therapy obviously carries a high risk of bleeding. Warfarin prolongs the clotting time that's assessed by the PT laboratory test, and it has to be closely monitored. Just some other details about these Lovenox. You saw a picture, I think, of those earlier. They come in pre-filled syringes. It can be administered by patients at home using that pre-filled syringe. Otherwise, don't worry about any of the details there. And then lastly, I know it's kind of hard for you guys to ask questions, but please feel free to email me with any questions. I'm probably going to figure out some things to attach to kind of maybe summarize this lecture. And then hopefully, if you guys haven't listened to this yet, when we've had our Zoom talk, that's okay. I'll have you listen to it afterwards, but make sure you're doing your discussion board. You know, that question was somewhere in here, and there'll be some other questions on your discussion board for you to answer as well. So I hope you guys are managing well. Stay safe, stay away from everybody, and I will talk soon. Bye.